Cool. I think we're going to go ahead and get started. So it is 8 o'clock, 8:01. Well, 8 o'clock in Texas, and we're going to go ahead and get started. So this case happened in the emergency department. It was a case I saw. I worked this case with a physician about 2 months ago. Super interesting case. I hope you all enjoy it. Maybe you've already seen the blurb. You probably did from the email or the other announcements, but let's go ahead and introduce the case. So, case this is a 59-year-old male brought to the emergency department by EMS. His chief complaint was right groin pain, and it radiated to his right foot. The pain was sudden in onset, and it began while he was standing in line at a sporting event. So be thinking about your differentials already, and if you want to be bold this early, you can go ahead and start shouting them out in the comment section or the chats, just so everyone can kind of know what our differential is going to be. A little bit more history. This guy is unable to walk, unable to ambulate due to his pain. He does also admit to some paresthesias, and he says that his right leg is heavy. Denies any recent trauma, no back pain, no urinary symptoms, no abdominal pain. Past medical history is significant only for hypertension, smoking, and no prior surgeries. All right. A lot of people coming in. Testicular torsion is an excellent guess. Make sure you switch your "to" to all panelists and attendees, not just all panelists, before you send a chat, because I want everyone to see it. But I'm seeing testicular torsion, DVT, dissection, osteonecrosis is good, arterial occlusion, acute arterial embolism, AAA, a lot of vascular stuff. I like it. Okay, so let's go. I wonder why y'all are thinking vascular so early. Maybe someone can be bold and say what they're thinking vascular for already. Current medications that he's taking is amlodipine and ibuprofen as needed periodically for pain. All right, so we're already listing some of the differentials. Keep listing them, and also list your reasoning why, if you don't mind. I'm going to continue on. I think for the most part, everyone's listing out some pretty good ones, though. DVT, osteonecrosis, AAA. And yeah, Lauren is saying the paresthesias make her think AAA. It's good guesses. Let's keep moving. Review of systems. Constitutional, none. HENT, none. Let's see. Basically, the ROS is there in yellow. Right groin pain with radiation of the foot. Right leg paresthesias. CVA, acute arterial occlusion, cauda equina syndrome, femoral hernia. All right. Vital signs. Y'all are on a really good track, by the way, with your differentials already, because you know it's got to be something kind of cool, or else we wouldn't be doing a case about it. Here are the vital signs. Definitely an elevated heart rate. Blood pressure is really high too. Everything else looks pretty normal here. Laura is saying, make sure you switch it to panelists and attendees before you send it. But Laura just said Fournier's gangrene, which I like. I think that's the first time I've seen that one, and definitely want to keep that on the differential, especially for the groin stuff. Anything in the groin, you just got to undress your patient and take a look at it for sure. Even with the radiation to the leg, you want to make sure nothing like that's going on. So here's physical exam. I've got the important stuff yellowed, all the positive stuff. What do y'all think on this physical exam? And as soon as you have looked through the physical exam, start sending in what you want to order. What labs, what imaging, anything like that, in order to kind of nail down the diagnosis. I would love to hear your thoughts. Okay, so leg ultrasound of the right leg, lactate, yeah. ABI, excellent. Leg ultrasound, D-dimer. So yeah, everyone's kind of jumping on the bandwagon of this right pedal pulse being absent. That's certainly the thing that kind of stood out to me from his physical exam. But yeah, everyone's on the right track. Arteriography, CBC, Chem 8, LDH, CRP, lower extremity ultrasound. Yeah, absolutely. Yeah, everyone's really on the right track. So let's move on. I wanted, well, was there anything else here? Yeah, this guy was a little diaphoretic, and he definitely did on his neuro exam. There was some diminished sensation in the right lower extremity. It wasn't completely numb or anything, but he reported diminishment when you tested it bilaterally. The diminishment was on the same side that he was feeling the pain. So definitely something going on. And I think everyone seems to be on the right track. This is a vascular issue here. So everyone's been throwing out some pretty good ideas. Let's take a look at kind of the differential I had going. And I broke it down into three sort of different categories because he had three main symptoms. Groin pain can be a hernia, muscle strain, but you can also have a lot of referred pain. Kidney stone can refer to the groin, a AAA, a dissection. I think someone threw out a few other things there that were good. Testicular torsion for sure. Pulseless leg, you definitely, I mean, once you know that there's no pulse in that leg, I mean, you kind of have to figure out what's going on because that's kind of the most severe finding that we have so far. And there's really not a lot of things that cause pulselessness in a leg, but for sure it could be an arterial embolism or an arterial thrombosis, ruptured AAA, dissection, or trauma. But in this case, he didn't really have a history of trauma. And then with paresthesias, it can be neuro, but it can also be vascular as well, like an ischemic change, electrolytes, and there's other things that can cause paresthesias. So workup, y'all already threw out quite a few things already, and a lot of them were really good. Let's start with labs. So labs that I definitely ordered, I mean, these are pretty standard: CBC, CMP, a UA. Why would we order a lactate or an LDH? Why would we order that specifically? I'm just curious if anyone wants to answer that. And make sure you switch it when you send in the chat. Make sure you say to all panelists and attendees, make sure you change it. Good. Yeah, Julia says ischemia for sure. I mean, your LDH is going to go super high for ischemia. Even if you've got infarction, especially, it's going to go high. Any sort of necrosis or tissue death is going to cause that to go high. Okay, so then imaging, we had some good ideas already. EKG, I mean, I know this technically, I mean, I always categorize it as an imaging study, but why would we get an EKG? Can anyone think of why I ordered that? Or just for the sake of discussion, what are we thinking with an EKG here? Good. Yeah, Ellen, right on the head. AFib. So with AFib, as you know, I mean, if you've got a patient with AFib and they're not anticoagulated at all, they can definitely form a clot in that left atria. And then you run the risk of throwing a clot if that thing breaks free and goes out into the systemic circulation. So EKG was one thing we ordered. Point of care abdominal ultrasound. We're in the ER, so we've got an ultrasound right there to grab. Doing an abdominal ultrasound to see if there's a AAA that might have ruptured or any free fluid in the belly or anything like that. This guy really wasn't complaining of abdominal pain though, so that might be a little bit unlikely, but still we did do that. And then the other two things we ordered were a CT aortogram to check out the aorta for a dissection. And then also we ordered a CT angiogram of the right leg. You can also get an arteriogram, which is just basically an X-ray with contrast to see if there's any sort of filling defect in the arteries and try and identify a clot. So that's what we ordered in the emergency department as the initial workup. Let's check out some of the findings. So here's what the guy's EKG looked like. As you can tell pretty quickly looking at this, this wasn't his actual EKG, but this is just an example of a normal EKG. There's no AFib. Specifically, that's the main thing I wanted to look for. Yeah, normal sinus. There's no signs of any sort of atrial fibrillation or any other ischemic changes or anything like that. All the T waves look normal. The ST segments look normal. It's a normal EKG. Labs. This is what we got. Normal on the white count. Normal hemoglobin. Platelets are normal. So everything's normal there. CMP. Again, Everything looking pretty normal here. UA came back. I mean, maybe a subtle UTI or an early UTI on the UA, but you know, nothing crazy. Here's what the ultrasound of the aorta looked like. We could do this super quick right there at the bedside. Such a growing thing in medicine in general, not just the ER, to utilize point of care ultrasound. And that's what we did. And the aorta caliber was completely normal. And normal is 3 centimeters or less. So, and you look at it in the AP and the transverse diameter. So very, very sensitive for a AAA, an ultrasound is. So, I mean, if you are concerned for a AAA and you don't see one on ultrasound, you can be fairly confident, actually extremely confident, that there's not a AAA there. So that's reassuring. So let's summarize what we have so far. 59-year-old guy, hypertension, comes in with right groin pain radiating to the right foot. There is a absent pulse on the right foot. There's no pulse on the right foot. And there's no AFib, at least not presently. And there's no AAA. And his labs are pretty much unremarkable. I did not order a lactate dehydrogenase or LDH, so I don't have that result for you, unfortunately. So what are everyone's thoughts? Is anyone thinking anything differently at this point? From y'all threw out some really great ideas. Have we narrowed it down anymore at this point? What are y'all thinking? And make sure you change it to, I keep having to say this, but I'm sorry, but make sure you change it so that everyone can see. So it's going to all panelists and attendees. So we've got arterial occlusion, iliac occlusion, clot, ischemia in the leg, absolutely, blood clot. Okay. So now remember, a clot in the leg, I mean, that could have actually formed in the leg itself, and it could have been thrown from somewhere else. Generally speaking, if it's thrown from somewhere else, we're usually talking about AFib coming from the heart. Those cardiogenic arterial clots are the most common in terms of embolism. But what about a thrombus forming in the leg? Generally speaking, that's going to be in a patient who's got long-standing, peripheral vascular disease. Maybe they're going to have decreased leg hair and so forth. But it seems like that's where everyone's still at. So we did order the CT angio of the right leg, but before getting that back, we had some developments for this patient. ED course for him. So about 45 minutes after he arrived to the department, a nurse started to notice that he was kind of becoming weak, a little lethargic, not really speaking clearly, and he became unresponsive. The nurse was unable to palpate a pulse, not just in the right leg, but like anywhere. Then the patient stopped breathing, and at that point, code blue was activated. And they started chest compressions. So everyone came rushing in and trying to figure out what's going on with this guy. Does anyone have any ideas what might be going on? All right, we're having a lot of PE talk, pulmonary embolism. Wow, everyone's thinking pulmonary embolism right now. And someone wants to get a head CT. Not a bad idea to get a head CT in a patient that just kind of goes unconscious like that. I'm curious what you're looking for though with the head CT. Is it, are we worried about like a possible stroke? Is that why we're thinking? The blood pressure at this point in the case is that he actually does not have one because he's in cardiac arrest at this point. A lot of PE talk. CVA, yeah, someone's saying that they would get the head CT because they're worried about a stroke or a brainstem stroke, embolism. So why are we thinking PE? How do those symptoms correlate with one another? We're thinking he had maybe a DVT in the right leg and then that traveled to the lungs. Is that what everyone's thinking? Okay, Ali says yes, pretty much. Okay. So in a patient with a DVT, certainly they're at high risk for a pulmonary embolism. and a massive enough pulmonary embolism, they will definitely go into cardiac arrest, drop their pressure, and so forth. But Dennis is asking the question that I was just about to ask everyone. Pulselessness doesn't necessarily mean it's a DVT, because, you know, if you're dealing with a DVT, we're talking about the veins, and the veins are not really what produce the pulse necessarily. So any sort of clot in the leg that is producing an absent pulse, we're worried about an arterial clot as opposed to a venous clot. So, you know, the connection between a clot in the leg and a pulmonary embolism makes sense. But in this case, we're worried about an arterial occlusion. So that doesn't mean this patient can't have a PE, but with regard to, you know, the risk or the likelihood of someone having a pulseless leg and now he's having a PE, it's a little less likely. I just want to make sure that's clear there. So an arterial clot, you know, is on the outgoing circulation, right? Going from the heart, away from the heart towards the periphery. It's got to go through a capillary bed, right? Before it turns into a vein and starts returning back to the lungs, or back to the heart and then on to the lungs. So less likely that this would be a DVT. It's still possible, but usually you would still have a pulse with a DVT is the point that I'm trying to make. And you can have a heart septal defect. That is true. That is a good point. You can have like some sort of an ASD or a VSD where the clot could have originated in the venous supply, and it goes up through the inferior vena cava into the right atrium, and then goes through an ASD into the left atrium. And then now we can throw that clot back out into circulation, and it could wind up in the leg. So DVT turned into an arterial occlusion definitely could happen for sure. But it's less likely unless your patient has an ASD or a VSD. I believe either could cause that. Let's see, some other people are saying things. Arterial problem, not a problem with the vein, dissecting somewhere. Yeah, JC saying that this could still be a dissection. Maybe a fat emboli from a hip fracture. Yeah, that's a good idea. Left ventricular thrombosis from AFib. Absolutely, that's still on the differential for sure. Patient is a smoker, causes hypercoagulation state. Absolutely, making you more likely to clot. Femoral dissection, somewhere else mentioned. Hypovolemic shocks from a ruptured dissection. Absolutely. Could also be an emboli from cancer. And I don't believe there was any significant family history. Sorry, just trying to address all the questions I see there. Let's move on. So, okay, the code blue was called. Myself and about 15 other people rushed over to the room, and this is what the cardiac monitor showed. So, mind you, this patient does not have a pulse. And this is what their cardiac monitor was showing. So remember from, yeah, everyone's starting to type what I was leading us down to. From ACLS, this person's in pulseless electrical activity, or PEA, because they've got a great looking strip. I mean, if you just looked at that, you'd say, okay, that's normal sinus rhythm, which it is, which is fantastic. But this patient does not have a pulse, so it's PEA. And what are we going to give the patient who's in PEA? Obviously, we're doing chest compressions. We're breathing for them. And everyone is saying, yes, give epi. And Krista hit it on the head and said, don't shock. So let's talk about PEA. So PEA, you'll remember, is part of your ACLS trainings. You're doing CPR on this patient. It is a non-shockable rhythm. So we do not need electricity for PEA. It's just like asystole in that regard. And really, there's only one medication that we tend to give as far as ACLS goes. I mean, obviously, if you identify an underlying cause, treat the underlying cause. But for PEA, for the ACLS guidelines, it's just epi and continue CPR. So let's continue. It's a non-shockable rhythm. Can anyone tell me some of the differentials, or not really differentials? Yeah, the differentials or most common causes of PEA. Because that's the goal, right? I mean, this person is more than likely, when you've got a patient on the table who's in PEA, they're probably going to stay in PEA unless you find out what's the cause and fix it. So Kristen Hayworth is correct. Hypovolemia is one of the common causes. Severe hypovolemia can cause PEA. Thrombosis, says JC. Cardiac tamponade, that's another one from Chummy. Some of y'all are putting in answers that are absolutely correct, but no one can see them. So make sure you flip off your 2. Make sure you say it to all panelists and attendees. But yeah, cardiac tamponade, severe hypovolemia. We got tension pneumothorax. That's one of them for sure. Nice. Okay, so I'm going to start showing them up here. So there's 3 major mechanisms. The first major mechanism for PEA, and these are most common, these are not the only, but the major ones would be severe hypovolemia. So this could be from a ruptured AAA, this could be from a dissection, this could be from third spacing somewhere, or if there's trauma with known bleeding of some source. And it's got to be a pretty severe hypovolemia. Obstruction to the circulation. So this is another one that causes PEA, and there's 3 main causes, 3 things that cause an obstruction in the circulation: a tension pneumo, cardiac tamponade, and a very large pulmonary embolism. So those are the 3 things, and if you think about them, we'll talk about those in a second. I got like pictures to kind of help illustrate, but those are 3 things that would cause a severe obstruction to the circulation right around the heart area. And then the third major mechanism would be pump failure. So like decompensating heart failure, for example. Let's go to the picture. So this is a picture of a tension pneumothorax in process, right? So that's where you've got air leaking out of one of the lungs. In this picture, it's the right lung. And that air is leaking into the pleural cavity, and the air is not able to go anywhere else. So it stays right there, and it just compresses that lung and makes it shrink down more and more. And it actually, what starts to happen, what actually makes it a tension pneumothorax is it starts to shift everything, the mediastinal shift that occurs. So all those major arteries and veins coming off the top of the heart start to shift contralaterally away from the tension pneumo. This puts a lot of pressure on the vena cava. Remember, the veins don't have a super strong wall around them. They're not very muscular the way arteries are and the aorta is. So they compress much more easily. So that compressibility makes it susceptible from any sort of pressure coming over into the mediastinum. It's going to start to kink off the vena cava, and you're going to get decreased blood flow through the heart. So that's one of the ways you get decrease or an obstruction to circulation, to be a tension pneumo. Cardiac tamponade, this is where you've got blood and fluid or whatever it may be leaking into that space around the heart, the pericardium. And as it fills up, it constricts movement of the chambers of the heart, and those chambers can't re-expand large enough to fill with blood to therefore be pumped out. So that's how we obstruct outflow or circulatory outflow from the heart with a tamponade. And then a pulmonary embolism. This picture here on the right, you can see the lungs and the pulmonary arteries coming off the top out of the right ventricle there. I mean, this is a pretty severe amount of clot burden in this example, but I think it illustrates the point. If you've got a large PE or multiple PEs, or like Nafur just said, saddle pulmonary embolism, it could definitely cause severe obstruction to the circulation. Okay, do we have thoughts? Let me see, hang on. Okay, so let me say, this is what happened, continued in the code blue. We gave epi, we intubated the patient because you always want to get a really good airway to make sure we're giving them as much oxygen as we can, continuing CPR. What else can we do? Does anyone have any idea? And what do we think's going on with this patient? I mean, we already ruled out a AAA. It could be a PE, but I mean, that doesn't explain the pulseless leg and the groin pain. Well, I guess the DVT could explain groin pain, but it doesn't explain a pulseless leg. So what could we do as far as making the diagnosis, figure out what's going on? Okay, I'm seeing people saying point of care ultrasound. Absolutely. What are we going to ultrasound? Oh, there we go. We got an enough here says get an echo. So we could get an echocardiogram. Look at the heart. Laura says get a fast exam to check for fluid in the pericardium. Absolutely. That is exactly what we did. The emergency room attending I was working with, very skilled with the ultrasound machine, and was able to put the cardiac probe right there on the chest and take a look at the heart with the ultrasound, looking for one of the causes of PEA. There's tons of causes, but one of the more common causes of PEA, especially in a person who we know has got something vascular going on, did an ultrasound of the heart. And here's what we saw on the ultrasound right here. I will admit, I'm not super good at interpreting ultrasounds. It does help that we've got nice turquoise labels and arrows and so forth, and it's like a picture perfect image telling us what's going on. But who can see what's going on, and who can tell me what the diagnosis is right now? Yeah, for sure. Cardiac tamponade. So that's the diagnosis. Now, how does that, yeah, cardiac tamponade is definitely what's going on. That's why this patient has no pulse anywhere. I'm not sure, I didn't look this up. I'm not sure of an example that I can think of where cardiac tamponade could necessarily cause a focal pulse deficit like we had in this gentleman at the beginning. He had pulses everywhere else. It was only the right foot we couldn't get pedal pulses. That wouldn't necessarily be explained by cardiac tamponade alone. But it is true, based on the ultrasound that we see here, the reason this guy is in PEA at the moment is cardiac tamponade. So that's what's going on for sure. And what's the treatment for cardiac tamponade? How are we going to get this guy's heart pumping again so that he can produce a pulse? Yep, drain it. Absolutely. We need the needle. So at this point, we proceeded to pericardiocentesis, okay, to drain that fluid. And you can see in the example here, I mean, it's a pretty big effusion on this example picture that we're using. We use the ultrasound in order to guide the procedure as well. So let's talk about tamponade. So this guy has blood filling the pericardial sac or the pericardium, increasing pressure within the pericardium, and it's compressing the right ventricle. Okay. As that happens, you're unable to fill the right ventricle. This decreases the cardiac output. And that's why we developed PEA, because we're not having any cardiac output. The electrical activity of the heart is going great, right? That's why his EKG looks phenomenal, at least for now. But this patient's in tamponade. Y'all already said it. The treatment is pericardiocentesis, which looks like this. Here's a couple pictures right here. This guy's got basically, this isn't an actual picture of the patient. This is just from the internet. But the most common way to do it is kind of this subxiphoid approach, because pretty much any patient, you're able to locate the xiphoid process, even if they're pretty large. And what you do is you get a pretty long needle, like at least a 4 or 5 inch needle. Like a spinal needle is usually the closest thing you can grab, like for an LP or something like that. And you want to insert the needle just underneath the xiphoid process at a 45-degree angle, and then you angle toward the left shoulder from that point. So you point it up towards the left shoulder, advance slowly while aspirating until you start to get anything fluid drawing back into the syringe. And we did it with ultrasound guidance to help, which was kind of cool. I hadn't seen it done that way before, but that was, like I said, this particular doctor I was with was kind of a whiz with ultrasound. So it was pretty cool seeing what all you could do with ultrasound. And we were able to look at the pericardium and watch it shrink while the fluid was aspirated, which was really cool to see. So we were able to pull off about 10 cc's of fluid, and it looked like blood. I mean, it didn't look like any, like in sometimes you get like an inflammatory, like with an inflammatory pericarditis or something like that. It didn't look like inflammatory fluid, it was blood. And we were able to remove 10 cc's. The unfortunate thing is that there was really no change on the cardiac monitor, which is not too surprising because the cardiac monitor didn't look that bad, right? But still no pulse. And that was the problem, is, you know, he continued to not have a pulse anywhere. And so we continued CPR. We did that for another 5 minutes, repeated the epi, because you want to repeat that every 3 to 5 minutes on pretty much any cardiac arrest patient, and repeated the cardiac ultrasound and saw that the pericardium had refilled once again. So what we did is we repeated the pericardiocentesis again, got 15 cc's of blood this time. Still no change. So the patient continues to be in PEA. We're doing this for about 25 minutes or so at this point. And then I think we did another like couple rounds of CPR and at least one more pericardiocentesis, but there was absolutely no change. The patient continued to be in PEA the whole time. And so the time of death was called, and that was the end of the case. So unfortunately, we were unable to get this patient back. And why did that happen? So like, what happened? That was what I was wondering when this was all over. I'm like, and I was still confused. Why did this patient have no pulse in his right foot when he came in? And then all of a sudden he's got cardiac tamponade. What's the connection? Can anyone tell me what the connection is? Let's see. Krista has said something back. She said maybe he has underlying vascular disease in the right leg, so it was more affected by the low flow than other areas. I like that idea. That's a really interesting idea. So what you're saying is chronic vascular disease that's been there for a long time, therefore more susceptible to a problem when you get tamponade. So that's where he saw symptoms first. I think that's an interesting idea. Never had a foot to begin with. Plot twist, he never actually had a foot. This was a patient who had undergone a below the knee amputation. Forgot to mention that. That's why he had no pulse. No, that's not the case. Okay, so let's go on. Let's summarize what we got. 59-year-old male, pulseless right leg, PEA, develops PEA due to cardiac tamponade. So going back to our differential, it was here, dissection. Now, I will say, at the end of our shift, we were not 100% sure, but we assumed it was probably a dissection that caused the pulselessness in the right foot. And then that dissection traveled up all the way to the pericardium and started to involve the pericardium, and then you get tamponade as a result. So that was what we thought. It was later confirmed on autopsy that that's what happened with this guy. So let's talk about aortic dissection. Okay. What are y'all's thoughts about this case overall? Going back to the beginning of the case when it first started, and I told you that we had a man with groin pain radiating to his right foot. Some people were saying dissection back then. I'll tell you that that was not the first thing that was on my mind, not until pulselessness was found. What's the thing that strikes you as odd about this patient presentation, knowing now that he had an aortic dissection that was causing everything? Okay, so we're seeing, let me scroll up. Y'all are answering so fast, I can't keep up. No searing back pain, no abdominal pain or chest pain. I agree. Those things were really throwing me as well. All pulses present except the foot. Interesting point. Unilateral pulselessness, says Ahmed. Same sort of idea there. Abdominal ultrasound normal. Stable vitals. The fact that he walked in the door with just the groin pain. Absolutely true. He technically did not walk in the door, but yeah, the fact that it was just groin pain was his only complaint was odd. Yeah. Okay. Well, I think y'all are hitting it on the head. So, for one thing, curious to me, there's no chest pain. Like when I think aortic dissection, the first thing that comes to my mind is chest pain or back pain, tearing, ripping chest pain, or even radiating to the abdomen, even sometimes threw me off completely. Um, the other thing is unilateral pulselessness. That could absolutely happen if the dissection is after the bifurcation of the aorta. If it's, maybe you've got a dissection in the descending aorta and then it extends into the bifurcation, right into the iliac, or even all the way down to the femoral artery. And that could go just to one side potentially. So it'd be extending pretty far down, but that could explain how that would happen. But the no chest pain thing I had never heard of that. No chest pain. We'll talk about it in a second, but it's actually out there, and it's not super, super rare to have painless dissections. Let me answer some of the questions going on here. Let's see. Was he a diabetic? He had no history of diabetes. His blood sugar was normal when he was in, so I don't believe he was a diabetic. Only a smoker and hypertension. I agree. You want to hear, for the test, it's going to be something like, oh, horribly controlled hypertension, smoker, and Marfan's disease, or, something like that. Maybe something else in the history. The CTA of the right leg, no. I don't think anyone's able to see the question, but no, the CTA of the right leg was never actually performed. Neither was the CT aortogram. Unfortunately, the patient coded and expired before we were able to get those tests. Phrenic nerve palsy, Marfan's. No history of Marfan's. No history of aortic dissection for this gentleman. Let's talk a little bit about aortic dissection here. So aortic dissection. This is when you get so there's layers to the aorta, right? There's the inner layer, the intima, and then there's the media, which is in between, and then there's the external layer, the adventitia, and that's where you get that's where the muscle and so forth is located. Hang on, let me scroll down here. Let's see. There's a question. Could you have done an ultrasound of the groin to check for a dissection? I don't know. I've never heard of that. I suppose in theory you could, but I would have to research that and check it out. I did look up the sensitivity for an ultrasound to detect an abdominal or a thoracic aorta dissection. Not super good. It's possible to miss a dissection with ultrasound of the abdominal or thoracic aorta. So it's possible. The AAAs are easier to find than a dissection. Okay, so then we got, so I was going over just kind of how the aortic dissection takes place. So this middle layer, you get a tear in the intima, and then blood starts to flow through that into the middle layer, the media. And it's basically a potential space there. And this is where all the smooth muscle that goes around the aorta is, and it just fills with blood in that potential space. And unfortunately, it can just extend to go up or down the aorta, and blood is not flowing where it's supposed to. It's instead trapped in this middle layer of the aorta wall itself. Can you do arterial ultrasound with flow? Yes, you can. I don't think anyone can see you, JC, if you can change your to all panelists and attendees, but you're right. You can do an arterial ultrasound with flow, but you're right. It's not as sensitive as a CT angiogram or even just a regular arteriogram either. Had this guy had any recent procedures? No, no recent procedures. Okay, so let's go to the next slide here. This is looking at different types of dissections. So there's two ways to classify aortic dissections. The first way is using the DeBakey classifications, named after the famous heart surgeon. I think it's Michael DeBakey. Anyway, type 1, 2, and 3 are the way he does it. His way is a little more complicated than the Stanford, but this is kind of like stuff that you might know for board review. Type 1 is when it originates in the ascending aorta, and it propagates at least to the aortic arch and beyond it distally. So in other words, it involves the ascending aorta and at least part of the descending. Type 2 would be it originates in and is confined to the ascending aorta. So it's only in the ascending. That's type 2. And then the DeBakey type 3 is when it originates in the descending and extends distally retrograde, but it only stays in the descending. And then the Stanford classification is all based on whether or not it affects the ascending aorta. So type A would be a dissection that affects the ascending aorta, regardless of where it starts. Type B is a dissection that does not affect the ascending aorta. So it's basically a yes or no for the Stanford classification, type A or type B. Does it affect the ascending aorta? If so, it's type A. So that one's a little bit easier to remember. Type A affects the ascending. And then, yeah, Nephew, the guy probably then had a type 1 aortic dissection. That's a good point. While we're looking at this picture, we should talk about how it pertains to our patient. He initially came in with a pulseless right leg, right groin pain. That tells us that it's probably down in the lower region, the descending aorta, probably down towards the bifurcation where we're involving the iliac arteries. And then also he wound up having a cardiac tamponade, so we know it also involved the ascending aorta. So really, unfortunately, this guy's, and I don't remember the details. I didn't get all the detailed report from like the autopsy and so forth. I just heard from the autopsy report that yes, it was a dissection. But obviously for this guy, it's also involving, you know, the pericardium. So it's got to be a type 1 where it's involving both. According to the Stanford classification, this guy would also be considered a type A because it does, yes, involve the ascending aorta in order to get all the way around and reach the heart itself. Okay, let's move on. So aortic dissection, risk factors would be chronic, poorly controlled blood pressure, high blood pressure. It's increasing risk with age, male sex, and connective tissue disease. So like Marfan's or Ehlers-Danlos. Here's how they typically present, which I'm sure y'all remember, but anterior chest pain, that's classically assigned to the ascending aortic dissection. The back pain is if it's distal to the left subclavian artery. I don't think that's 100%, I mean, with every case, but that's kind of the classic is a chest pain or a back pain that is tearing in nature. Could also be abdominal pain, depending on where it's located. Other common presenting symptoms would be syncope, a heart attack, focal neurologic deficit, or a pulse deficit. So when you think of a pulse deficit, you got to think of dissection, among other things. And here's the thing that really kind of made me not sleep well that night, if I'm being honest. There's research, several papers that have shown that it's actually more common than originally thought to have an aortic dissection, an acute aortic dissection that has no pain. In fact, the number that I read on a couple papers was up to 10% of aortic dissections are painless. So 1 out of every 10. It's not like you see a lot of aortic dissections, but 1 out of 10 is not a small number, in my opinion, to have painless. So that kind of made me think, my goodness, how common, you know, to have painless aortic dissection. Has anyone else seen that? I'm curious if anyone on here has had a patient with a painless aortic dissection. If you could tell me about it, or you know, give us the stats on the patient and so forth. Okay, let's go to the next question. Aortic dissection. Oh, so when you're going to make the diagnosis to figure out, is this in fact aortic dissection, the gold standard would be to get a CT aortogram, and that would be very helpful in finding a dissection. Or a AAA. Oftentimes we're considering both when we're looking for one or the other. There's also a aortic dissection detection risk score, or the AD-RS. Now, this is something you could definitely utilize to determine how risky your patient is for having a dissection. Obviously, our patient, you know, he was basically, you know, he coded. So, I mean, we weren't really considering how likely or unlikely to figure out what tests we were going to order. We were throwing everything we could at him. But here's how you could use it in the stable appearing patient. So there's basically three categories. There's predisposing conditions, there's pain features, and there's physical findings. And if the patient has anything, so like take the predisposing conditions, if the patient has any of those things under that column, it's 1 point. If they have all of those things in that first column, it's 1 point. So it's just kind of like, do any of these things exist as far as predisposing conditions? Then you go to pain features. This guy didn't have any pain, unfortunately, so he would get 0 points for pain features. I'm trying to think. He wouldn't have any of the predisposing conditions either. So he'd be a 0 for the first two categories. And then physical findings for this guy, evidence of a perfusion deficit. So that'd be pulse deficit, systolic BP differential, focal neurodeficit, murmur of aortic insufficiency, hypotension, shock state. So you can get a maximum score of 3, or you can have a minimum score of 0 using this right here. And here's what you do with those numbers. So if you've got a score of 0, they're considered low risk, 6% prevalence. 1 would be intermediate. Anything over 1, so 2 or 3 would be high. So if you've got a score of 0 or 1, get a D-dimer. That's the recommendation, where they say consider getting a D-dimer, which is the better way of saying it, because if you have a high suspicion and you don't want to trust a clinical decision-making tool, you don't have to, but this is just kind of a guideline that you can follow. If elevated, that's when you would move on to a CT aortogram, so greater than 500 or whatever your lab uses for normal for a dimer. Score of 2 or 3, they recommend just going straight for the CT. So that's kind of how you would utilize this risk score right here. Let's see. Okay, not everyone can see it, unfortunately, but one of the viewers sent in that they indeed had a patient that had aortic dissection, 21-year-old, with shortness of breath and no pain. It was a Sanford A, and she lived. So amazing. Still kind of scares the heck out of me that patients can have aortic dissection without pain. That's good that they live, though. 21-year-old, that's good. And then let's see what else. Maybe if we had gotten a chest x-ray, would clue in for a widened mediastinum. Absolutely. We'll talk about that in just a second, actually. I think on the next slide. Yep, chest x-ray and aortic dissection. So if you're curious about how sensitive a chest x-ray would be for a dissection, I would say that it's not a slam dunk to rule out aortic dissection. It's not good enough, but a chest x-ray will be abnormal in approximately 90% of patients who have an aortic dissection. And here's the things you would see. In 56 to 63%, they'll have a widened mediastinum. 19% will have a left-sided pleural effusion. And then 48% will have a prominent aortic arch. So that aortic knob that you see on the chest x-ray is a little bit wider than normal. I would only consider this as a screening tool if the patient is extremely low risk. And I would probably couple this with a dimer. So in any patient where you're even thinking dissection, you've got to have like, you got to really cover yourself, right? At least that's how my mind is kind of trained to think from working in the ERs, covering, making sure you're looking for the life threat first. So chest x-ray and D-dimer together for sure would be helpful for those very low risk patients. Here's a picture of a widened mediastinum and a prominent aortic knob. So 1 is the mediastinum, 2 is the aortic arch. So how would we manage? We're not going to go too in depth as far as how to manage an aortic dissection. Just keep it kind of broad. When it's an aortic, an ascending aortic dissection, a DeBakey type 1 or 2 or a Stanford type A, surgical management. So if it's the ascending aorta, it's surgery. The descending aorta is generally managed medically. So what we would do as far as, just the initial goal would be to control the blood pressure and control the heart rate. The goal heart rate is 60 to 80. The goal blood pressure is a systolic of 100 to 120, so fairly low, lower than, average or normal. I forgot to mention this earlier, but I put it here. Patients are often going to present, when they have a dissection, they'll often present with elevated blood pressure. Usually that's in their history, but it's also going to be present when they actually present. And then generally speaking, in order to get to those goals of the blood pressure and the heart rate, beta blockers are kind of the first line. A lot of people like Esmolol. It's got a nice short half-life, so it's easy to titrate the dose so you don't overshoot it and, you know, drop their pressure a little too low, and you can get them on a pretty good control at that point. Labetalol and metoprolol are other options as well. So just getting their heart rate and their blood pressure in the right range and admitting them to the ICU, right? That's where they need to be. And getting all your consults in order. So definitely your vascular surgeon is the guy you want to talk to, or the girl you want to talk to, whichever it may be. Let's see, what are we saying? Why the high blood pressure from Millie? Not sure if it's for sure reason why it's always high blood pressure tends to be. I think it's mostly because that's their in their past medical history. Let's see. Okay, so let's go through some key takeaways. As I'm going through these, start thinking of questions, or just go ahead and type out your questions for me and for everyone else, because we're going to start kind of wrapping up here as we get closer to the end of the hour. But I just want to go over some key takeaways from this point, or from this PowerPoint, from this case. The first one for me is always check pulses. Okay, so the second point is, no, seriously, always check pulses. The reason I make a big deal out of it is, I don't know, I feel like sometimes you don't want to take the patient's shoes off, you know? I'm just going to be completely honest. If you don't want to take the patient's shoes off, I get it, but it's really important. Take them off, check the pulses, especially when there's any sort of lower extremity complaint or something in the groin or back pain. Always check pulses in a back pain. You just want to make sure there's no deficit as well. Don't jump straight to musculoskeletal as far as the etiology. That's something, and I'm not trying to lecture here. I mean, these are the kind of the takeaways I myself took away from this case, because I found it to be a very humbling case. The fact that this guy had a dissection, I had no idea from the beginning. But don't just jump straight to musculoskeletal. You know, this patient, I think if you kind of squinted your eyes and kind of turned your head one way and you were really overwhelmed with other patients, you would hear groin pain / pain in the hip region, radiating down the leg, no trauma. You might try to make it sound like sciatica or something. Maybe, you know, if you actually didn't remember to check the pulses or chose not to, it'd be a lot easier to kind of justify that. You know, what if we just got an x-ray on this guy and, you know, checked the groin to see if there was any sort of, you know, mass that might say, oh yeah, he does not have a hernia. There's no testicular tenderness. His abdomen is non-tender. There's no like bony tenderness in his lumbar spine. He's got good range of motion. This guy couldn't walk, so that's a red flag. But let's say he could walk, and let's say he did not code in the ER, and let's say you did not check his pulse in his right leg. You know, you could have just kind of written it off as musculoskeletal. So to me, that made me kind of nervous, because you see tons of musculoskeletal complaints, no matter what practice setting you work in. So that's one of the things that I really took away from, is like, sometimes it's not musculoskeletal, even when it kind of starts to sound that way from the beginning, like groin pain, radiating to the right foot, you know, that's usually sciatica. Sciatica is so common, even though it's usually like low back pain. Let's go to the next one. So just a refresher on the differential for a pulse deficit: arterial thrombosis or embolus, ruptured AAA, aortic dissection, or trauma. Of course, you can have direct trauma to an artery that would diminish the pulse, or you can have significant edema, swelling around the area that would cause like a compression, a compartment syndrome, which could cause pulselessness as well. More takeaways: the three major mechanisms for a PEA would be severe hypovolemia, obstruction of the circulation, and pump failure. And then the three examples of obstruction to circulation would be a tension pneumo, cardiac tamponade, massive PE. Those are the takeaways there. I'm going to take a break and answer a couple questions here. Why was the abdominal ultrasound normal? Just confused by this. So the abdominal ultrasound looked normal on this patient. I'm not sure if it, you know, could have been user error, but I know that the sensitivity for detecting a dissection is not as much of a slam dunk as like looking for a AAA. So the sensitivity is just not really there. It's not good to rule out a dissection of the abdominal aorta with ultrasound alone. And so that it was just not seen in this guy's case. Pulsus alternans, would that be present with dissection or pulsus paradoxus? Let's see, pulsus alternans, if I remember correctly, I'm kind of getting on the spot here. I'm pretty sure pulsus alternans is when the heart is swinging forward and backward because it's a cardiac tamponade situation or a pericardial effusion. So would that be present with the dissection? Pulsus paradoxus. I'm thinking alternans is the one for the cardiac or for the pericardial effusion. I'm not 100% sure on that, Kristen. I'm going to be totally honest with you. I'd have to look that up. So I'm not going to even venture a guess because I'd hate to be wrong. Logistic question. When performing CPR, once PEA was noted, how can the cardiac ultrasound and pericardiocentesis be performed? Good question. So for this patient, you always want to take a pause every few minutes and do a pulse check. And we were able to time the pulse check with when we would do the procedure. So once we actually, okay, let me back up a little bit. When we're performing the chest compressions on this patient, in order to perform the cardiac ultrasound, you can actually view the heart with ultrasound, not necessarily looking directly over the chest. Because I see your question is, that's where the hands are. That's where we're doing compressions. How are you going to do an ultrasound without interrupting CPR? You can actually visualize the heart fairly well by looking kind of like from the right upper quadrant region, looking through the liver, because you want to always look through like solid structures because the sound waves transfer very well. So he was actually looking up like from the right upper quadrant up towards the heart and had a really good view in order to see that. So that was kind of how it was done. Now to perform the actual procedure of the pericardiocentesis, we did pause chest compressions to do that. So that's kind of a big thing, right? When you're doing ACLS or any sort of CPR, don't stop chest compressions any longer than you have to. If you do a pulse check or if you shock the patient, resume chest compressions right away. That's always the big thing. But it is possible to have a condition where, okay, what this patient needs more than chest compressions at the moment is for all that fluid around the heart to be drained off, because if that doesn't happen, then this is ultimately going to be futile, right? So this is a fatal condition in the patient's heart. So we had to stop chest compressions. And I think we were timing it. It was like somewhere around 30 seconds to 45 seconds, I think, which is longer than you want in a typical situation, but it was kind of necessary for this gentleman. Let's see, question. Not really a question, but when you have a minute, could you go back to the PEA slide so I can take a quick screenshot? Absolutely. You betcha. Where is it? Oh, did I pass it already? I'm not sure what slide you're talking about. The PEA. I think it's that one right there. Maybe I went too far back, but I'll leave it on here for now in case that's the one you're looking for. Electrical alternans is with the effusion on the EKG. That's right. That's when you get the electrical alternans, is when you've got pericardial effusion and you've got alternating QRS complexes. So like high voltage, low voltage, high voltage, low voltage on the QRS complexes. Let's see. Would you see this is from Chris, would you see a large difference in blood pressure if you checked the blood pressure in both arms in an aortic dissection? Yes, depending on where the dissection was located. So if it was in the right spot where it would only affect circulation to the right arm versus the left, then yes, or vice versa. Okay, I think this is the slide that you're looking for, Emmanuel, or Emma Valles, excuse me. Hopefully that's it. Okay. Does anyone have any other questions? I think we might have gotten through all the slides already. Let me go back and double check. I'm just going to pause on this one for a minute for someone who was asking for it. Let's see. Oh, yeah, obviously this was a pretty big takeaway. Not all aortic dissections are going to have the classic tearing chest pain, back pain, or abdominal pain, such as this gentleman. So consider in all cases when there's a neurodeficit, vascular deficit, such as a pulse deficit, especially when there's risk factors. So consider dissection even in the absence of any pain anywhere in the chest or back. Consider it. Aortic dissection risk score. That was, the screening tool that we had talked about. And then the last thing, honestly, I feel like, if there's one thing that you might want to try and memorize if you're taking your board exam anytime soon, this is kind of high yield information for the board exams. So the DeBakey versus the Stanford classification. So that would be my recommendation, is just to make sure you got that memorized. All right. Well, we went over time just by a couple minutes here, but I think we had a really good talk, really good discussion. Thank y'all so much for joining and participating. Y'all, as always, teach me a lot as I'm reading through the chat box here. I know there's a lot of very experienced clinicians that come on, and I appreciate y'all for speaking up and for, I always think of the case one way, talk to the people I work with about the case, and I learn a lot from them, but then I present it on here and it's like, I think about it from a whole new direction. And, honestly, there's differentials that are on here that, we weren't even talking about in the ED when this happened. So really appreciate everyone participating, putting their comments in the chat, and hope y'all learned a lot. Hope y'all enjoyed it. Thank y'all so much. I'm not sure when the next one's going to be, probably sometime next month. Hopefully y'all can join for that one as well. Just keep an eye out for an email about it. Obviously, anyone who's listening to this or on here probably already knows about our podcast. That's what I do as well, as I host the podcast. So if y'all have any questions that you want addressed on the podcast, go to askmedgeeks.com and that'll send directly to me. So it's just a little form you fill out and put the question in, and we can make it a topic on the podcast or just answer it as a quick question at the end. And then there's tons of other stuff going on with Medgeeks. At our website, you can find the information for all of it, but we're on Facebook, Instagram, and YouTube, putting out content like every day, basically. So it's not just me, it's not just Andrew. There's a lot of people that are a part of Medgeeks and contributing content for everyone. So check us out. Everything's at our website, medgeeks.co. So check that out. And I look forward to doing this next time. We'll talk to y'all next time, y'all. Thanks so much. Have a good night.